Over to me. Okay.
Everyone,
I'll share my.
Over to Dr. Sridevi, Dr. Rose.
Yeah, we'll just formally introduce you to the
Thank
group.
you.
Yeah, thank you so much, all the participants, and thank you so much, Ross and Dr. Raj Kirmani, for joining us on time. And thank you so much for agreeing to be part of the session. Another year, we have done the same last year, which we had very wonderful interaction and discussion last year. So we're having another session on this topic. And a lot have changed in a year, probably, especially in India. So we have more topics to discuss, more way to go about it. I'd like to introduce Dr. Ross Taylor, who is a medical director of Farrington Hospice, West London. She is also a commissioner on Lancet Commission on Value of Deaths, which we have all referred to, still referring to and on many contexts as when we describe the situation happening across the world. And she was former clinical director of Hospice UK, which is actually an organization for hospice movement. And Dr. Rose has over 30 years of experience in palliative care. And I was so interested to know about HPAL. Maybe we'll talk about it later, a digital platform which provides essential palliative information for both informal and professional carers. So that might be something that we might want to adopt to India probably in the coming days. So thank you so much, Ross, for being with us for today's session again. And I would like to introduce Dr. Raj Kirmani also. He's the Director of Clinical Services, Pulmonology and Critical Care, Yashoda Super Specialty Hospital, Ghaziabad. And he is in the field of pulmonology and critical care for over 30 years. And isn't it wonderful to have him here to talk about withholding withdrawal of care and the ethics behind it? Who else can do the session in an Indian context? And he was also a former president of Indian Society of Critical Care Medicine. He played a very crucial role in devising guidelines for end-of-life care and palliative care in India, and many, many more in terms of the legal aspects of withholding withdrawal of life support in the country. Thank you so much, Dr. Raj, also to be a part of the session. Now over to you, Ross and Dr. Raj.
Thank you. I will share my screen. Just looking for slide share now. Yes, I need to share my presentation slideshow, play from start. Okay, I hope everybody can see me.
Yes, perfect.
Yes.
You can see my slides?
Yes.
Yeah. Okay, thank you. Firstly, thank you so much for inviting me. I'm delighted to help again with the faculty. And I'm going to just talk for half an hour or a bit less on the UK, or maybe the global north, the Western approach to withholding or withdrawing treatment, which still is a very, very difficult decision in many cases. I'm starting with this quote, which really reflects on modern medicine, that there is so much that we can do. And I'm thinking of the current patients in the palliative care unit where I work. I was just arguing half an hour ago about whether we should scan somebody just because we can. Actually, this is an Indian man with very advanced bowel cancer, severe pain, likely to have an abscess in his pelvis, but he's not well enough to have it drained and he doesn't want to go back to hospital. So I'm wondering, why should we scan him? So the challenge in modern medicine is, just because we can do something, should we do it? So I'm interested in thoughtful medicine. So just to remind all of you, you're all experienced doctors, these are the 4 pillars of ethics that we consider when we're making a decision. And these are at the back of our mind with every decision about every medication, every scan, every intervention, and every conversation. Autonomy, beneficence, whether we're doing good, non-maleficence, whether we are causing harm, and justice, which is about equity and equality in medicine, which certainly we don't see completely in the UK. But autonomy perhaps is the most interesting one in the context of this discussion, because it varies across the world how much autonomy the patient has, how much autonomy the doctor has, how much autonomy the family have. And certainly in the UK and probably North America and Europe, autonomy for the patient is now primal. But this isn't the case in the rest of the world, and probably not in India, although, as Dr. Raj has just said in our conversation before we started, on an individual basis, autonomy probably is gaining in importance in India. Autonomy. So just if we're thinking about withholding and withdrawing, if we think about this green line, a young woman, and I can think of a case diagnosed with motor neuron disease, or ALS, as they call it in the States. At some point, at the second red arrow, this lady, 39, young with motor neuron disease, went into respiratory failure and would have died at this point unless non-invasive ventilation was started 24/7. She had used it intermittently, but she was now totally dependent on this machine. And she lived, oops, sorry, going back. She lived several months, and at the point at the end of the green line, I'm just moving my pictures. At the purple point, she asked for ventilation to be withdrawn. She was still able to communicate with what's called a light writer, and she wanted the ventilation withdrawn. Now, I remember a nurse saying that's euthanasia, but it's not euthanasia. It's a decision to stop life-prolonging treatment. She would have died naturally at the second red arrow, but modern medicine prolonged her life, and she was allowed, although it was a difficult decision for everybody around her, because she died very soon after the ventilation was withdrawn. She was sedated and she died within a few hours of the ventilation stopping. That isn't euthanasia, but a lot of people would see it as euthanasia. So carrying on. So just a quick summary of a case that changed the law in the UK. A young man called Tony Bland was at a Liverpool football match in Sheffield, a town in the middle of England, and there was a terrible crash and many people died of hypoxia. It was a terrible time. 96 young fans, football fans, died. And Tony Bland was crushed, hypoxic, and he went into a hypoxic coma. And he was able to breathe alone, but he couldn't swallow. So he was fed through a nasogastric tube for many, I think, nearly 2 years. His family challenged through the courts that he would not have wanted to exist in this comatose condition, just being fed. The feeding was obviously keeping him alive, feeding and hydration. And this was a key change in English law. And the judges allowed his artificial food and fluid to be withdrawn, and he died a natural death, and there was no criminal liability. And this was a case that changed medicine in the UK. And now our General Medical Council, which governs how doctors behave, this is a quote: "There is no absolute obligation to prolong life, irrespective of the consequences for the patients and irrespective of the patient's views." So we are not obliged always to prolong life. And artificial nutrition and hydration is now considered a clinical intervention, which is very, very difficult for some families. We're also guided by the Mental Capacity Act, which is due for updating, but it's still law since 2005, 17 years ago. And it helps And I think about this, the Mental Capacity Act, every time I make a decision, particularly if somebody is beginning to lack capacity. And there are 5 principles. We have to presume that somebody can make a decision. We have to support decision making. So if somebody can't hear well, we have to think about hearing aids. If they can't read well, we need to help them with information. And if somebody does have capacity, we have to allow unwise decisions. So for instance, somebody with gangrene of their leg, who we may be able to save by amputation, may choose not to have an amputation and may die of gangrene or sepsis. If somebody doesn't have mental capacity to make a particular decision, and this is all decision-based, then we have to act in their best interest. And that involves knowing what they would have thought, knowing what they have said, and knowing what the family know about somebody's wishes. So where I work, the patient's wishes will usually be the deciding factor. So this could be a quote from somebody who is fed up with life, who wants to perhaps stop dialysis. I can't bear this anymore. I have no quality in my life. I hate being looked after. I'm a burden. My time was up 2 weeks ago. I just want to die. We don't see this often, but when we do, we have to listen. So I'm quite interested in the difference between stopping various things. So stopping antibiotics when somebody's septic, stopping chemotherapy, stopping dialysis, stopping ventilation. These are all the same ethically, but some will lead to a very quick death. Stopping dialysis, if you're totally dialysis dependent, people will die within a few days, perhaps a week or so. Stopping ventilation, if you're totally dependent, you will die within minutes, possibly hours. Stopping chemotherapy, well, you might actually feel better. I see a lot of people stopping chemo and actually feel better for a while, but obviously the cancer will progress. And stopping antibiotics. We give so many antibiotics, often in the last weeks of life. We're just auditing it, in fact, many more than when I started in palliative care. So stopping treatment. Stopping treatment does feel different from not starting treatment or withholding treatment. But legally and morally, it's considered the same. And it is all about intention. We never intend to bring death sooner, but some of our decisions will obviously do so. Stopping ventilation when somebody is totally dependent. The intention is to relieve suffering, although that patient will definitely die. But if ventilation hadn't been started, they also would have died, perhaps a few weeks or a few months earlier. So we consider no ethical difference between these decisions. But not everybody would see that as the same. And we often have very difficult conversations about stopping ventilation, and particularly in the palliative setting about stopping PEG feeding or nasogastric feeding. It does seem like abandonment. And we find decisions about feeding the most difficult. And ultimately, we're talking about the sanctity of life versus the quality of life. And these are decisions that underpin all that we do in palliative care, if you think about every case you're currently looking after. So as I've said, who decides? If the patient has capacity, then absolutely they will have the final say in the UK. And I suppose I want to spend a few minutes now and a few cases on the conversations that we need to have that will guide us as to whether we stop treatment or not start treatment. And we are very influenced by Atul Gawande. Many of you will know his work, an Asian American surgeon who's written a pivotal book called Being Mortal, which I recommend to you all. We give a copy to all of our new doctors and nurses working in palliative care. And he came up with a very simple framework of conversation. And these are brave but important questions. It's all, if you want to look up his original work, it's called The Serious Illness Conversation. And you can access the framework online, The Serious Illness Conversation. So his questions, which we use all the time. What is your understanding of your illness when I meet a patient for the first time? What are your fears or worries for the future? What are your priorities for the time that's left? What outcomes are unacceptable? I often meet people now who just don't want to go back into hospital. And what would a good day look like? Now, what would a good day look like gives me a clue about what matters to people right now. So when I am meeting a patient for the first time, we obviously ask all about symptoms, all about the history, we ask about the family, but these questions are perhaps the most important in deciding on the next steps. So we ask what matters to you, not what's the matter with you. And what matters to you is always a surprise. Often people come in with severe pain and I ask them what matters to you. And I think they're going to say the pain or the vomiting or the insomnia. But actually, what matters to them is spending more time with their family. And we are not having enough of these conversations, even though the concept of advanced care planning has been around for a long time now. In the UK, you can have conversations about your wishes, but that's not legally binding, but it will inform decision-making if you lose capacity. So if you have recorded your wishes, then that will be part of a best interest conversation if you lose capacity towards the end of your life. You can legally decide on what you don't want to happen in certain circumstances. So if you lose the ability to communicate through a stroke, or lose the ability to swallow, or lose consciousness, you can dictate legally that you don't want to be ventilated, or you don't want to be artificially fed, or you don't want to be dialyzed if you go into renal failure. And that's called an advanced decision to refuse treatment. Very few people do this, and we would like more people to do this, because then we would know and the decision wouldn't be left to the family. So this is quite a dramatic quote. Modern medicine could be seen as a futile attempt to solve humanity's most profound existential problems through biotechnical means. And sometimes I feel I am in that world. I'm referencing a great paper by a well-known London GP who's written a lot about overtreatment in medicine. This is quite an old paper published in the BMJ, British Medical Journal. This is another quote we could discuss. In hospital, you can only die when medical staff declare you can die. So briefly, towards the end of my time, I want to mention two cases, and these are based on my experience in the palliative care unit where I work. Avtar was an Asian businessman, successful. He had advanced prostate cancer involving most of his bones. He was chronically anemic because the cancer was involving his bone marrow. He had been treated twice for high calcium. During those episodes, he had become muddled, sick, and confused. He'd had multiple antibiotic courses, some intravenous in hospital, he was in a lot of pain from his bones. So we had those Atul Gawande conversation with him. His biggest fear was becoming immobile and more dependent for personal care. He hated the thought of incontinence or needing people to come into the home to wash him. His goals were to be alive for his daughter's wedding, which was in 4 months' time, and to be at home. He didn't want to come into the palliative care unit, and he really wanted to stay at home. He couldn't bear the thought of being paralyzed, although he knew it was a risk with the state of his spinal cord. And sadly, he did develop spinal cord compression and some pressure ulcers. So his options, after listening to him, were that we supported him to stay at home with carers visiting to help his wife and his son care for him. We optimized his analgesia at home. We did one more transfusion in the palliative care unit, our hospice, and then got him straight home. And he was able to attend his daughter's wedding in a wheelchair, as his paralysis had deteriorated by then. After the wedding, about 3 weeks later, he developed a further episode of hypercalcemia, and it was decided with him and with the family that he didn't want to come back in to the hospice for further treatment, and he was managed at home with medication and increased nursing, and he died peacefully at home, and his goal to be at his daughter's wedding was met. A second case, again, based on my experience, this was the case of Jane, who had motor neurone disease, and her swallowing was getting worse. She was aspirating, frequent chest infections, and her goals were not very ambitious. She wanted to use virtual reality to revisit the places she loved in the world and the places that she may never be well enough to visit. She was suffering a lot from the secretions that she could no longer swallow and from her immobility. And in terms of the conversation, she wanted to, well, she was accepting of trading in quantity of life if she was unable to communicate. She didn't want the focus of her life to be all about food and feeding. She wanted to spend time with her daughter. She needed a lot of care because she could not move any of her limbs by now, but she was still just about able to swallow with what we call risk feeding. She agreed to be admitted to a nursing home where there could be 24/7 nursing. She declined to have a PEG tube, which would have prolonged her life a little, but possibly not improved her quality of life. We managed her secretions, and she lived another 8 weeks, a few more courses of antibiotics, and she died peacefully in the care home. So we opted not to start feeding. And in the previous case, we opted not to treat hypercalcemia. So I put it to you that although we intervene a lot, at the heart of palliative care is relationship, not just intervention. The picture on the right of this slide used to be the logo of the American Palliative Care Association. And it's an interesting painting by an artist called Robert Pope, who died of lymphoma. And you can't really tell who's the patient and who's the family, but it entwines the hug and the medical intervention, the spiritual and the medical. And I think that's what we strive to do in palliative care. This is a favorite quote of mine from David Roy, who was an ethicist in Montreal, we need to promote dying without a frantic technical fuss to squeeze out a few more moments of biological life. Sometimes I feel that's what we're doing. We want to promote dying without being racked by pain, and we want to die in the presence of people who can drop the professional role mask and relate to each other as a human being. Just a final word on cardiopulmonary resuscitation, which has become such an issue in the UK because we are obliged to discuss this with every patient. And it's a difficult discussion sometimes because so few people understand what resuscitation really means. For doctors, it means we will not try to restart your heart or your breathing. But for families, it means we will abandon you. So we are obliged now to discuss whether we are going to try to resuscitate somebody when somebody's heart stops. And all of the people on this call, I think you all know that if somebody's heart stops at the end of a long and chronic illness, it's very unlikely that restarting the heart will bring any quality of life, even if it's successful. So the last word will always come from Dame Cicely Saunders, who is seen as the founder of the modern hospice movement. How people die remains in the memory of those who live on. And that's where our obligation to be more thoughtful in our decisions. And just the last 2 or 3 slides are to share what's going on in the rest of the world. Certainly in the global north, as I've said, there's a focus on autonomy. The AM, oops, that's my watch. There's a focus on autonomy. This is the American Medical and the American Nurses Association, that patients with capacity have the right to refuse treatment. Decisions will be based on an advance directive, if there is one, or on a surrogate decision maker. And informed consent is really important. Similarly, in Canada, where they've gone even further, and there's now medical assistance in dying since 2016. Again, the Canadian Medical Association gives guidance on withholding and withdrawing treatment, and there are legally binding advance directives that some patients will make. Holland, absolute extreme, where euthanasia has been legal for many, many years. But what the Dutch have done is they have really good ethical guidelines to help with decision making for these really difficult decisions, worth looking at. But if you move further east, and we're going to hear about India shortly, in Japan, for instance, there is a much greater focus on preserving life, both from doctors and from society, and there's much more reluctance to withhold treatment or withdraw treatment, and the focus is less on the patient's autonomy and more on family decision-making, which I've certainly seen when I've done some work in India. Although things are changing, and there is a growing interest in autonomy and guidelines to allow patients to make their own decisions. And I think that's my last slide. And if you are interested in guidance, certainly how the UK guides doctors, then these are 2 very critical documents that which we refer to the whole time: the General Medical Council, Good Practice in Decision Making, and a particular one from the Royal College of Physicians on the left about clinically assisted hydration and nutrition, which, as I said, are some of the more difficult cases that we share. So I'm going to stop sharing. I haven't talked at all about HPAL, but I hope we'll have a few minutes at the end and I can perhaps share the screen. So stop sharing. There we are.
Thank you so much, Ross. It was, a lot of powerful messages and a lot of clarity. And I hope we'll also have clarity in the coming years, Dr. Raj, probably, to say that this is how we do. And this is how the cultural beliefs affects the decisions in end-of-life care. Can we take the questions together in the end after Raj's presentation so that we can discuss more about it? Thank you so much, Rose. Over to you, Dr. Raj.
Yes, so I'll proceed, and so that we can take the questions together. That makes sense. I'll share. Oh, sorry. Where is the share screen? Yeah, sorry. Yeah. Is it visible?
Yes, sir.
To everyone? Yeah.
Yes. Yes.
See, my perspective is a little different. My vantage point is the ICU. Right. I don't have the great privilege of being a palliative care person. Increasingly, I feel it's a more powerful way to give than intensive care. But what I've grown to understand is we must integrate palliative care with critical care. Not as two distinct specialties, but as a model in which every critical care specialist also has palliative care competencies, and he takes help as needed from the palliative care specialist. So why so? That is a question I'll address. Because in our midst, we see a lot of death, and death is the ultimate reality. And death has inspired so much of talk in the fields, not only of medicine, but philosophy, literature, art, what have you, metaphysics, whatever. Every human endeavor has touched upon death somewhere or the other. So there's a huge amount of intersection when it comes to death and dying experience of a human being. And in the words of Thich Nhat Hanh, a Zen master, cloud never dies. It means there is a continuity in life and death cycle. Cloud turns to water, water turns to vapor, back to cloud. But you see, this truism often escapes us. Right, death is taboo subject, death is something, to be avoided. And it all comes to the sharp focus in the rescue culture in the ICU. Right, everybody has to be rescued, everybody's physiology has to be set right. And you don't think about death as a natural culmination of life, or death something that is inevitable part of life. The Lancet Commission on the value of death, by Libby Salnauer et al., published last year, was a real eye-opener. They called it a value of death. It is not something extraneous to life. It is a part and parcel of life. And we have not come to value death, or to even to try and understand death as an individual level and in the context of being a caregiver, right? In the intensive care culture, I don't mean palliative care culture like Ross Taylor's. I mean the intensive care culture has been rescue, more, right? It is not so reflective as reflexive. So we have come to understand in critical care, it is counterproductive to be death-defying, to be death-denying, right? To feed the myth that medicine can conquer death, or advances in medicine can do the impossible. Much has been achieved. Great has been achieved since the 1950s till now. But you see, the stories do come to an end, and that end needs skillful management, thoughtful management. There are different other skills come into play. This is what we need to understand. Because 20% of all deaths take place in an ICU in the US. We don't have data, but we can see lots of death happen in the ICU, even in a resource-poor country like India. The resources are available to many. not available to most. So you see, it is suboptimal for both sides. Okay? Those who have access to critical care and those of modern care and those who don't have. On the other end, there is a paradox of increased suffering towards the end of life, which we must address rationally. So you see, it's a reality also in the ICU. There is excess treatment. Dr. Taylor referred to that. There is excess treatment, from the GP perspective, but there is excess treatment even more so in the intensive care perspective. And this has been time and again shown in various papers, in the Dyspropicus trials sponsored by the European Society of Critical Care Medicine, and lead author being Ruth Byers. It was demonstrated across Europe, about 23% or so surveying the doctors, and more than that, surveying the nurses. We find excess treatment going on in their midst. We don't know what is happening in this part of the world. We don't have much empirical data. But suffice it to say, the dying experience is not great overall. Right? Many cultures have improved upon it, and this struggle to improve the dying experience has been going on at least for the last 30 years. The first, the case laws in the US were in the 70s, and there have been case laws in the UK. UK has had a tradition. It's the land of Cicely Saunders, after all. So it's had a tradition, unwritten law of providing compassionate care. It has been a beacon light, although not perfect, but then it shows a role model. And we were very late, slow to catch up, right? So these movements had taken place. The case laws addressing withdrawal, withholding were back in the 1970s in the US. The first DNA order was written in 1974 or thereabouts. So these basic questions are still there in India. You see, the questions which have been addressed and reasonably settled, not perfectly settled, but reasonably settled in the global north or in the west. We are still grappling with the fundamental questions because we are confused about many things. So firstly, the definition. What is withholding? You don't start an intervention which, in our judgment, is non-beneficial, right? Or in fact harmful. How does it harm? I'll tell you. And withdrawing is once an intervention started. Say, mechanical ventilator, and proving to be non-beneficial, in fact, very burdensome, we withdraw it, take it off. What are the ethical underpinnings? Ross had addressed this. She's shown us the 4 principles. The bioethical principles have been sort of defined in the late 70s, Beauchamp and Childress. Now then 7th or maybe 8th edition going on of that book now. And that has been a foundational concepts for us in the intensive care. Autonomy, beneficent, non-beneficent, and social justice. So from the rights perspective, see, it's not that we prescribe something, we initiate something, we start an extraordinary process of life support, and the patient or the surrogates have no say in the matter. It can't be. Anywhere in the world, it's not just cultural. It's really logical and humane that something done to your body must be having an input from you. It can't be just unilateral. So you see, there may be cultural variations around the world in how we treat terminally ill patients, but the suffering and the issues involved are very universal, and we must examine them at least. So autonomy is very fundamental. But then from the times of Hippocrates, we have certain promises made to the patient, beneficence and non-beneficence, right? These are duties of care which also can't change. It is very fundamental. See, I must always act for the benefit of my patient. It's an unspoken promise we all make under all circumstances, even through dying process. It's not that I treat and it doesn't help and then we are facing death of the patient, we wash our hands off. It can't be. We have to see the patient through that process as best as possible by medical standards and by the human touch. And then non-maleficences, we promise not to do harm, or if there must be harm and inherent in everything, it must be greatly overweighed by beneficence. So this is the standard. I think they don't need too much debate. They are truth, they are virtues, which we work with. And justice is a little more complicated. Justice means that we act fairly, and that is also very fundamental. We act equitably, that's more difficult to handle, as an individual level, because it's a whole ecosystem that matters. Obviously, acting justly also means that we don't misuse resources, right? So if you hook up on the ventilator or terminally ill or in excess or useless treatments, you are denying many the right to live. So that's not acting justly. So from all manner of ways, we have to take these decisions which are ethical in the ICU. Now the problem arises that people mistake it with euthanasia. Even in India, that was the problem. When years ago in 2006, I approached the Indian Law Commission saying that we had no laws at all governing treatment limitation decisions. The first response of the honorable judge who was in charge of who was leading the Indian Law Commission said, no, this can't be done. This would amount to euthanasia. So it took a while to explain how it's different. Ross also spent some time addressing this issue. See, euthanasia is active killing, and we cannot lump the entire range of end-of-life decisions into euthanasia, which was happening in India for a long, long time. Even DNAR was thought to be euthanasia. Can you believe? So we took pains to explain that it is only an active intervention on the part of on a voluntary request by the patient, on the part of the physician, to a well-regulated process, active euthanasia is possible in the countries or regions where it is being done today. Euthanasia is not what we are asking for in India. We are asking for appropriate withdrawal and withholding, which are treatment-limiting decisions when they don't serve any purpose. They are pointless. See what I mean? So that is different. It is an intention not to interfere. Okay, it's an action of omission to use modern medical technologies to sustain life when those technologies are not serving any purpose or actually harming the patient and the families by destroying their dying experience, by destroying them financially, emotionally, and so on. See, withdrawal, when it comes to withdrawal of a life-sustaining treatment, people have a problem even today. After so much of water has flown under the bridge in the world, today in India, withdrawal again fills people with a lot of apprehension and worries. Am I committing euthanasia? But it's ethically reasonably well settled. There's a very good consensus and also legal position that withholding and withdrawing are just the same. And the current Indian position is also that they are same, legally. Now, withdrawal could be antibiotics, transfusion, dialysis, ventilation, and these days we have even more complex ethical dilemmas. Withdrawal of ECMO, extracorporeal membrane oxygenation. Because life is being sustained by artificial circulation and oxygenation. So if it is being sustained, how to shut it off? What is the state of life in a patient on ECMO? And sometimes ECMO at least is extracorporeal. It's outside the body. There are inside the body intracardiac devices, for instance. Yes, you put intracardiac devices which give shocks intermittently when there is a ventricular VFib. Can you shut it off? When the patient is suffering, terminally ill, and multiple shocks rack the system. Ross said you should not be racking in pain. So that is a part of our caregiving. So they rack due to the shocks. Can you shut it off? Now, you see, these questions are inevitable as there are advances in medicine, and we have to apply our minds thoughtfully, and the same principles apply. After all, withholding and withdrawal coming from the same principle of not providing or removing what is not beneficial or painful or unwanted or burdensome. So the same thing applies to all artificial intervention, be it artificial nutrition, because it's again a medical intervention, be it ECMO, right? Be it ICD or intracardiac device, I mean. Of course, you can't remove what has become a part of the body, like a biotechnology, like transplant. Okay, you can't remove a transplanted heart because it's become part of the body. You can remove a pacemaker perhaps, but not a transplanted heart. You can't remove a transplanted kidney or destroy chemically a transplanted pancreas, right? Because they have become part and parcel of the tissue of the system. So this is the way our ethical reasoning, ethical understanding is evolving with evolving technology. See, the idea that intensive care and palliative care must integrate, and we must embrace the principles of palliative care, which are really great, which is the mission of medicine anyway, to touch the human being as a human being and to look after the human being appropriately, right? And holistically. That's what palliative care is. It controls suffering. I mean, mitigate suffering, not just treat physiology. So you can see in this paper by Randall Curtis, Randall Curtis was a pioneer in integrating palliative care into intensive care medicine from Seattle. We lost him very unfortunately early due to amyotrophic lateral sclerosis, or bulbar form of motor neuron disease in February this year. So he gave us this model that a decision making in end of life care, right? It is impacted by a whole sort of thing, whole ecosystem. The national culture, institutional policy, national healthcare policy, down to clinicians, attitudes and behavior and their own fears and phobias and understanding of life. And then also patients and families similarly, their belief systems, their fears, their apprehensions, their traumas that they've faced, all these things impact on our decision making. And this construct is so true in India. For a long time, we have grappled with national policy. Some kind of national policy is going to happen now. bear fruit, I think. Soon we have got a national sort of legal position now. The national policy is not too far off. But we still have great problems with institutional culture. Most institutions, whether teaching hospitals, government hospitals, or in the private sector, are very apprehensive of taking treatment limitation decisions. They keep asking the same questions and don't wait for an answer. They wonder whether this is euthanasia, but they don't wait for you to answer it, right? They wonder whether there are laws. Keep asking, but no, they won't wait to hear. And then clinicians are beset with these worries. You know, there have been surveys of clinicians. The earliest one was back in 2006, which said that physicians are very scared of the law, and they're very scared of the hospital administration and their policies when they take an end-of-life care decision. This is a major barrier. Nothing much changed. Then there was the Acme paper, maybe back in 2016 or so. You know, it was Asian survey, you know, starting out of Philippines and a lot of Asian countries that included India. Again, we share with our Asian brethren their apprehensions about the law. And because we are not properly trained in ethics, bioethics, we are trained in how to put a ventilator, intubate, we are trained how to place lines, we are trained in robotic surgeries, we are trained in various cutting edge technologies, but we are not trained in ethics. We are not trained in how to talk, communicate, broach these subjects, understand them, take a rational decision. So nothing much has changed in physician attitudes until recently. Now there are papers yet to be published where I've reviewed. I think there was one recent paper last month. There was a online survey of 91 intensivists. More than half of them believe they must have treatment limitation decision on a regular basis in their ICUs. I have another paper which I've co-authored, which is yet to be published, where again, out of 200 physicians, we find a majority, that is 86%, believe that they should persuade their ecosystem, their administration, and they should go ahead with taking treatment limitation decisions because the suffering in our midst is huge. The consequences of not taking these decisions are huge to the patient, to the family, and to caregivers themselves. Because we have crisis of conscience, we have problems facing ourselves, and we have greater chances of burnout. Ross will remember this lady. So she died with great dignity and smiling, as it were, in the company of her family, in her own home, right? She had the nation at her feet, and this great lady had the foresight to leave in a will that she will be not fussed over, like she mentioned technological fuss, you know, Ross mentioned she didn't go through it. Oh, she went as she lived like a queen, right? So the world got to know the process of ordinary dying. You know, she left a great message in her death. And this was tweeted by Catherine Mannix. You know, I immediately picked up this picture from that tweet. A palliative care opinion leader and author. So this was the message from that great dying process we all witnessed all around the world. And such messages many others have given too. Like Barbara and George Bush, they both left an advance directive and both died at home, although all the world's technology is available in the USA. But this privilege, our own well-loved leaders did not have. A former prime minister and a singer of great repute, loved by everyone for over 50 or more years. Now she was 90s. I think she started singing in her teenage, right? For a long, long time. So both of them died on a ventilator. And the first one died after being on a ventilator for a decade or more, finally on ECMO. So you see, this is the difference between the global north and the global south. Because we are not addressing a very crucial point. What is the ethical framework of what we do? All right. What is the human underpinning of what we do? What is the mission of our healthcare? Right. So we need to address it, and there is no escape. There's no escape in saying that we are different, we are culturally different. No. We are not different in dying. We are not different in dying experience. We are not different in our suffering during death and dying. In fact, more so. Because this is a lot of out-of-pocket expenses in our country. 80% are out-of-pocket expenses. There is no universal healthcare system well established. Many are emerging, but they're not well established. So the potential for a huge avoidable suffering is great, and there is no escape behind so-called culture, because our culture doesn't obligate us to go on nevertheless. It is only a problem of communication. And no wonder you can see that in the latest quality of death and dying index published by the Lian Foundation in Singapore, and you can see UK as expected tops the list, and India as expected is bringing up the rear. You see, I'm a proud Indian. I love UK too. I've trained in UK. We must first and foremost we owe allegiance to our patients. We owe allegiance to our societies and the world society as well, right? So we must bridge the gap. You can see in the same paper the quality of death. They also talk to the country. They across many countries they had experts. So the experts had a questionnaire. What they consider most important in the care of the dying. So managing pain and discomfort, of course, tops the list. Symptom control. Clean and safe place for the family, of course. They go through a lot more than we imagine. We only look. There have been a lot of papers from Azoulay et al. In France, which demonstrate that 70% of families go through depression, anxiety, actually measured. Okay? A lot of them go through PTSD, post-traumatic stress disorder, and many even worse. The grief, complicated grief, the so-called complicated griefs. Now, these complicated grief may last a long, long time. Okay, may destroy your life. So the third point of being treated kindly becomes extremely important. This is a very powerful tool in this question of withdrawal and withholding and treatment limitation. Depends on your conversations and how well trained you are, experienced you are in the conversation. So you see, death need not be a morose experience. I've had the consent for showing this picture. In fact, the family itself took this selfie and gave me this picture. They were very grateful for the conversation, which could enable this. Right? So terminal cancer, now he was being in an ICU, going on a wild goose chase. We stopped everything. And here he is with his family, with his grandchildren. In most Indian hospitals, children are not allowed. most Indian hospitals, visiting time for half an hour. Now, how just is it? How kind is it? For any patient, it's unkind. But for somebody terminally ill, just disaster, right? So please have liberal visitation. You take these decisions, enter into a good conversation. They are, in fact, it is no disaster to be told that you're going to die. He is showing thumbs up, right? He struck up a friendship with me, right? We were very frank with each other. So it is not a disaster to have death. It's a disaster not to be able to seize the opportunity to touch the patient and the family in a humane manner. That is the way we have to see. It's a very striking appearance, isn't it? So you see, the holy personages in India, it's a very spiritual country. There are so many different religions. And there are so-called holy men who spend their entire life, in spiritual pursuits, and they have generally large following. Now, this personage who was reputedly 102 years old. Now, we don't know their age. Generally, it's a mystery when they were born and all. So I happened to treat him 7-8 years ago for ILD, interstitial lung disease, which is a very progressive, and treatment is very limited. So he went on oxygen for a long time. In fact, he was also on a peg after having been in a hospital, an ICU, on a ventilator, and great difficulty we could wean him off. He was on a peg for a year or so, and then now I was called again to see him 7 years later in his ashram, in the retreat. Okay, in the retreat, he was on oxygen and he was very breathless. He was being suctioned. You see, the survivors in ICU have told us that it's a most nightmarish experience. ICU is a nightmarish experience, a dehumanizing, depersonalized experience. And a lot of our interventions are more painful than we can imagine. Suctioning is one of the most painful, as declared by survivors. And ICD removal is very painful, right? And having something stuck in the throat is very painful. And then people talking over you and referring to you as the ILD patient is very painful. And being isolated, alone, not having family to talk to, is making you feel totally out of control and vulnerable. See, I explained to the followers, which are plentiful, and many of them were doctors, that time is coming. But they wouldn't accept. They wanted something done. They wanted him moved to the hospital. So this is the barrier. The society not having any conversation on death, it's unprepared. Though they had a long lead time, 7 years, 8 years, nobody had talked to, the gentleman about what are the prospects, what can happen, what would he like to have. No advanced care planning. I mean, it's unknown. It's in a different sort of sphere. So they insisted on ventilating him, though I said there's nothing going. So I argued stoutly. So we came to an understanding, which is called a time-limited trial. I said, we'll wait for 2 days. If it doesn't work, then we'll opt to withdraw. That's what happened. Ultimately, we took the patient to the ashram with anticipatory sedation and analgesia. We extubated him, waited there. You see, there is a ritual, death ritual among holy men, which means that you got to be buried. They're not cremated, although he was a Hindu. They are buried in the sitting posture or lotus posture. And that could not happen under rigor mortis if it had taken place in the hospital. So this enabled the proper, culturally, ritualistically proper send-off, goodbye to the holy man. You see, end-of-life decisions have been, treatment-limiting decisions, withdrawal, withholding have been easier to do in Europe. The Ethicus study, there were Ethicus 1 and 2, 15 years apart, across 35 nations. I think it included Israel as well. And the second one included India as well, right? So 15 years apart, what happened? It only got easier. Treatment limitations rose to 90% from 68%. And then there were more DNAR decisions, less CPR. Of course, we are seeing from the perspective of intensive care. How many people didn't come to the intensive care at all due to advanced care planning? This paper doesn't address that, but obviously that is also a success story of good advanced care planning. From the professional point of view, from a professional society point of view, Indian Society of Critical Care Medicine, Indian Association of Palliative Care, we wrote this guideline. It's a 20-page guideline, which is a review at that time of all the literature available on ethics and the process and the Indian law. So there are 9 steps to making these decisions. We integrated 5 more for palliation. So what are the steps? First step is, of course, to get to the idea that the patient is dying. So prognosis. So weighing the clinical facts. So we have to be experts in that, in weighing the clinical facts, using science. The scoring systems are not perfect, but they can be useful. To predict death may not be exact ever. Maybe with the AI now, you may be able to predict mortality much better. But then it has to be integrated with what is your choice, patient's choice. The 2 things are there. It's not just about dying. There are fates worse than dying, right? The disability, which is intolerable. When we get that to there through an iterative process, through a process of second opinion and third opinions and clinical boards, we come to an understanding within the treating team that there's a consensus within the team to transition to palliative care. Then you talk to the family about the options available, the current medical treating options available, and the options of not treating and going over to palliative care. This has to be explicitly, properly, patiently explained. This is only through conversations. So the most important intervention in this decision making for withdrawal, withholding are conversations. And there is a whole subject of conversation. How do you do it? How you structure it? And what should be the content and so on. But you do it properly and you get trained properly. Pending any decisions, you continue with full support. And once decisions are made, you carry them forward. However, although this had wide consensus within the societies, very few were implementing because they're worried about the law. As I said, the lingering worry about how it will be perceived in the law court carried on for a long time. So the crucial intervention of multidisciplinary family meetings should be done in the first 24 to 48 hours so that you set up a platform for mutual trust, okay, build trust. And different departments involved in the care of the patient must come together. There should be a pre-meeting with the patient, meet in a proper room, not in the corridor, not in the lift, not in the bedside. Structure the meeting, with certain principles such as value and spikes. Debrief the rest of the team once the meeting is done. what has happened now is, since we all hide behind the so-called lack of clarity in law and so-called barriers from the hospital administration, we take a very peculiar route in India, which is called Lama, left against medical advice, okay, a pernicious habit. You know, it's like Pontius Pilate's washing off the hands, right? Not facing the issue. There is a moral dilemma, there's an ethical dilemma. The family is suffering, you're not addressing that at all. You are getting them to sign a form called the Lama form, right? Then you're absolved of all legal obligations. The patient is going on a ventilator home, right? Or extubated and just sent home without any palliative care. So these issues are widely prevalent and they are to be strongly stated to be unacceptable. After a long battle and through certain case laws, which I won't go through, there were case laws in 2011, 2018, Common Cause versus the Union of India, where they formally accepted that withdrawal, withholding are legal, they are lawful, they are decriminalized, patient has a right to refuse any treatment. Okay. So these principles were well laid out on the basis of the right to autonomy and right to privacy, enshrined in the Constitution, the right to live, Article 21. However, they lost their way in a very complicated process. They wanted an oversight by the bureaucracy and by the magistrate, which is ridiculous and unworkable. So we said so, all right? So we submitted to the Supreme Court an appeal to simplify this process. So we succeeded. This was in January 23. You see, Supreme Court simplifies the order on passive euthanasia. In spite of our protests, they keep mentioning passive euthanasia, confusing everybody, right? So, but then the understanding is passive euthanasia means withdrawal and withholding. I won't go into the details of it. Now it has got simplified and it is workable. It's got 2 layers, two boards, both of them in the hospital, and not shackles from the bureaucracy, and the magistrate is gone, right? So this is workable, doable, and now our next campaign is to make it happen more often and more confidently with less phobias, right? And more patient-centered, family-centered, less self-centered. See, India needs a theory of change, right? What does it mean in a just envisioning? We must envision a more compassionate caregiving and more socially significant caregiving, and having a proper discourse in the society about death and dying, which is extremely important, and a hard look in the mirror what we are doing and why we are doing. Brainstorming about what steps we can take, and even if baby steps are taken, should be taken well, and we should put evidence together. More and more evidence is being collected, empirical evidence. Now different things are coming together. The law is coming together as well. Advocacy is coming together. More people are speaking up. And then there should be championship. In each hospital institution, teaching institution, there should be a champion for what is very, very just, fair, compassion. So let me conclude by saying that a conversation that began maybe 2005 or so, or maybe thereabouts, within professional circles alone, has gathered energy. It has built capacity. Now, more people outside the profession, in the civil society, there's a conversation. In the legal society, there's a conversation. So a change in attitude is inevitable. We are chipping away at it, right? And that is a prelude to cultural change. We must learn from societies which has evolved in this field much better than us. And particularly UK, I understand it's not perfect. They had a lot of problem with Liverpool Care Pathway. They had a lot of problem with the DNAR label. That is how we learn. We can't be perfect. And I'm glad they produced from the Liverpool care pathway fiasco, they produced a more creative solution. And so we must keep exchanging views, learning, and we can foresee the benefits, right? There are innumerable benefits. Firstly, the dying experience should improve for the patient. Firstly, all the rest are collaterals. There's been a lot of collateral damage. There'll be collateral benefits from this. And we must find pragmatic ways to translate it on the ground. Thank you for your patient hearing. I hope I've not exceeded time.
Thank you so much, Dr. Raj. Yeah, I'll just wait for any questions from participant side. Either you can unmute yourself or you can type it in the chat. And thank you so much, Rose, for I hope you will be sharing the link for Dr. Catherine when it's talk in June. We'll wait for that and we'll circulate among all the participants. Anyone is interested to join. Meanwhile, we'll wait for 1 or 2 minutes for any questions.
Good evening, sir. I'm Dr. Hina. I'm an anesthetist. I just had one question. Like we always write, like do not resuscitate in ICU. Like we've read, is it legally acceptable that we write do not resuscitate? It has been, the consent has been taken from attendant. Is it legal? Like legally, is it acceptable?
100% legal.
Okay, sir.
100% acceptable.
Okay, sir.
You know, this question has bedeviled everybody in spite of the fact that ICMR published the do not attempt resuscitation guidelines. And the Supreme Court has not distinguished or excluded DNAR from their withholding, being made lawful. So DNAR is only withholding. DNAR is not anything separate from that. Only thing is DNAR is limited to CPR. What we have said is, if there's a DNAR directive or order, all that it says is don't do CPR. That cannot be extrapolated to mean that you can withhold other forms of treatment. So DNAR is one simplest end of the spectrum of treatment limiting decisions. You know, progressively it's DNAR, withholding or non-escalation, withdrawal, right? And of course, medical assistance in death or active euthanasia being top of the pack. That is the extreme respect to autonomy, which many societies have accepted through a referendum process. Our country, we have not discussed that. We have only discussed withdrawal, withholding, and DNAR.
Yes, sir. Thank you, sir.
So do so, but see, everything should be properly documented, discussed. Don't do unilaterally. No, our court also says not to do unilaterally. I think now in UK also there's a law that one must discuss. You can't take a unilateral decision except under very, very clear futility conditions, right? In most other conditions, there are 4 or 5 conditions where DNAR applies. In 4 out of this 5, you must discuss. Most deaths in the ICU are predictable, yes, anticipated. So you do have time to discuss.
Yes. Thank you, sir.
There is another question in the chat, like how to or who defines futile treatment, when this is usually a cause of disagreement between treating clinicians, or maybe when to refer. Like we usually get those questions. Yes, we are ready to refer to palliative care, but then, I mean, how do we choose which patients to refer? What is the point of decision one? So both of you can take up that questions.
I'll take Ross's opinion first. Yeah.
Dr. Ross, you're muted.
So futility is never objective. It's always got to be viewed in the context of the patient's history and their goals and priorities, and with the family too. So what may be futile for one patient, for instance, a blood transfusion, because they've had 7 and they've never benefited. So whenever we do a blood transfusion in the palliative care unit, we always try to estimate benefits so that we know if we should do more. So there's no such thing as a futile intervention. It's always got to be seen in context. And if there's disagreement, then we need to come together with a multidisciplinary team, with the view of the family and the patient, if they have capacity to decide. But perhaps it's more useful to talk about benefit rather than futility. And in the case I presented briefly, if somebody wants to get to their daughter's wedding and they've got a very low hemoglobin, then of course transfusion isn't futile. But if somebody is barely conscious, not eating, in pain, and they have a low hemoglobin and the last transfusion didn't benefit, then it probably is a futile intervention. So I think it always has to be looked at contextually. Thank you.
You see, futile is not a word I'm comfortable with.
No.
Because it's too absolute.
Mm.
As Ross said, it is a combination of 2 things, right? And you see, futility judgment is, is bound to be inaccurate, except in very, very few situations. So the words that are being used across the world are non-beneficial, inappropriate, or potentially inappropriate, words like that. So we've got to understand that a lot of these are value laden. They are not absolutely objective. That is why 2 people must come together and in a shared decision, right? From the treating side and from the family side or the patient directly. There has to be a combo, then only you can get it right. So it's a subjective, objective exercise together.
Dr. Raj, one question there. So probably I have seen most of the places the ICU physicians invariably believe that this is beneficial, right? And then we have to advocate sometimes for not so being beneficial. I think that's what Dr. Prakar wants to know, how to come into would you like to call a third physician into the picture and the patient's family?
You see, one thing is, in a scientific environment, one must question beliefs, right? It's not a theological environment, right? Why do you believe? Why don't you ask your colleague? So the issue is, that is where discussion becomes very important. Discussion within team, discussion across team with the family. Because this is what we cogitate. See, even our Supreme Court says the same thing. Let it be a result of cogitation. That's a word I borrowed from the judges, right? So you got to brainstorm, in our words. You brainstorm about so many medical decisions, right? When to do a surgery or when to do an intervention, when to start a certain set of interventions. So this is, again, same principles apply. You have an idea. An idea is to be peer review at all times, and they are subject to scrutiny. You can't just be fixated on your belief, because that will result in a huge amount of suffering, and which is what we discussed. So training in ethics and training in thinking this way, right, has to be done. I think our environment suffers from lack of addressing these issues. We got fixated in certain beliefs. For example, we carry the belief that DNAR is questionably legal. Where from has it come? There is no law anywhere that I've seen. I've been sort of engaging with this for the past 2 decades. No law has ever said DNAR is not allowed. They don't even know what DNAR is. So if they haven't pronounced about something, there is no question of violating it. So these are beliefs we carry, and if we discuss like this, it may change our attitudes. And I showed you how physician attitudes impact on end-of-life decisions.
Yeah, I think in past few years, whichever session we talk about end of life care, withholding, withdrawal of care, the most common question that come up is DNAR legal in India? I mean, that's the most common question. Like, isn't it legally accepted? What is the document supporting that? Can we actually do it? So, yeah, now.
If the document is published, they are not reading it.
Yes.
So please, it is available in public domain, DNR guidance from ICMR. So if you're really asking that question, please Google search it, read it.
Yes. So just from what I've just gathered, so suppose when you are talking to a group of ICU physicians about this topic, we should start from the basics of ethics and take it from there probably to build a foundation like we did for today's session. We started with the basic principles of ethics and then probably take from there to the discussions on end of life care. Just take back point from today's session. I was just thinking.
I think that the difficulty is if somebody holds a belief, as Dr. Raj says, that life at any cost has value or sanctity, then that's a difficult discussion. And we've seen that with the very high profile cases of babies that have gone to court in the UK, where life at any cost becomes a decision for the court, and there's a fight between the doctors, the family, and the courts. And that's a very difficult decision if you believe that every day is sacred, whatever the condition of the patient. And those are the most difficult discussions I've had when we've talked about withdrawing treatment.
You see, when they talk about cost at any cost, I talk to them about the cost in terms of human suffering.
Yes.
You have to divert the conversation from economic costs, because that may appeal. There is a cost to the patient in suffering. There's a cost to the family in suffering, and to the healthcare system, right? An occupied bed, needlessly occupied bed. We need to discuss this more, because the consciousness doesn't change that easily. Awareness, only with repeated discussion, slowly you may make a headway.
I think you've made a lot of headway in India, though, Dr. Raj. I mean, it's interesting seeing those latest papers, which I look forward to reading.
Lovely. I'll send them over to you.
It's taken 20 years, though.
Absolutely. I'll send you my recent editorial where I summarize the whole thing. Yeah.
Thank you. Maybe it would, yes, it would be good for the whole group to be able to.
Oh, yes. I'll send it to you.
That will be a good read for everyone of us too.
Yeah. I think
Rajeshwari,
there is some evidence that it takes 17 years for a system to change on the basis of culture, and attitudes have to change before culture. And I think you might be getting there. Yeah,
I think we have cracked a certain threshold. But we have to make it happen. We, caregivers, have to do it. And we should, whenever we ask a question, we must resolve that question. Not let it hang there for 10 years. Okay, do the reading, do the discussion, do the implementing. You take one DNAR decision, document it there, you lose the fear. And you see that it was nothing.
Yes. Yeah.
It is the most humane thing to do. You might feel better. Family may be more grateful. That's happened so many times. See, relationship with families have improved a great deal ever since I've been taking, these decisions since early 2000s. And prior to that, my relationship was very tenuous. I also realized where I was making a mistake. It's not a transaction relationship. Ross told us it's a relationship, a fiduciary relation. The transaction may be a part of it, but the bulk of it is a relational exercise, isn't it? So if we see it that way, maybe our own perception of ourselves as caregivers improves and become more meaningful.
Sir, according to you, what are the barriers in providing end-of-life care to patients in ICU? What do you see? What do you think, like from your experience, what are the main barriers that prevent prevent doctors from providing end-of-life care to patients?
You see, the professed barrier was legal, right? Law isn't there, law isn't there. But I suspect that is a symptom of something deeper. We were hiding behind the non-existence of the law. We have not had a proper conversation about death and dying.
Yes, sir.
We ourselves are scared about death and dying. Right? We ourselves haven't looked at it rationally, humanely. Okay?
Yes,
And
sir.
we have closed our minds to whatever else is happening around the world. We were very happy to embrace all new technologies, right?
Yes,
Why
sir.
were we not equally receptive to all the developments in end-of-life care in the last 30 years? There have been rapid developments, great developments, great papers, profusion of papers. Almost in every issue of an intensive care journal of repute, there is a. So we ourselves have devalued the caring of dying patients, right? You know,
And
we
sir,
have
maybe
become, we were a little more paternalistic attitude, still prevailing. We have to
And maybe, sir,
treat people as people.
the institutional protocols are also as such, these are not protocolized as how to provide end-of-life care. I think that is also a barrier because
But
maybe
who creates institutional policies? We create.
Yes, sir.
No, nothing is handed to us. Why can't we cook our own meal? So the issue is you have to be convinced that you've got to do a bit more for your patient, right? What I'm doing is not enough. You get that feeling, gut feeling, that, I'm not doing enough, right? This is not the best I can do. It has to come from there. Then we have to understand there is an ethical underpinning of whatever we do. We don't have absolute power.
Yes.
Ross and I discussed power imbalance, in the initial chat. There's a huge power imbalance, and this is very sharp in India still. Hopefully it is coming down. More people are questioning, more people are coming with Google downloads and asking questions, uncomfortable questions. And good, this is good being uncomfortable. Because this great gradient makes you talk down to people, makes you ignore them as people. So if we move away from a more equal level of relationship, then we will treat them as people, and then we might get some humanizing of our critical care environment.
Yes, sir. Thank you, sir.
Good evening, sir. I have a question, sir. I'm actually working in Jharkhand, one of the rural areas among tribals. So most of the time, like people with cancer, we have enough time to counsel them and give them about all the death, all that we can tell them. But there are certain cases like brain hemorrhage coming. Even in that case, we get some time because this tribal, they are not able to take them for further treatment anywhere else. So still we have some time, but there are times patients comes to us in severe uremia, creatinine 2022, acute breathlessness. They come to OPD. Relatives are stressed, patient is stressed. They just want, and being with these tribals, what I have noticed is even if we send them for dialysis, I don't have dialysis in my center. It is a rural setup. I can easily push them out for dialysis, but it's very difficult. They may do once or twice dialysis. That is the end of it. Their pocket will be emptied. They will be fully debt. But that moment they come, it is not a non-patient. Suddenly a patient come to us with acute breathlessness, relatives are stressed. So we don't know what to,
See, what
whether
you're
to push
asking,
them out.
I think, Mary, what you're really asking is, sometimes it doesn't seem logical or appropriate to advise them dialysis. And the situation difficult. The situation difficult means that you need to enter into a conversation. Okay. You need to firstly be honest and brave in giving a prognosis. All right. Prognosis should be honest and it should be brave. It should not be, vague, nebulous, right? So that the family can't make anything out what you're saying. So you need to enter into a conversation, if possible, repeatedly. But in any case, even if you have a very short time, you must enter into a conversation, a frank conversation. I think that may resolve many of these issues. You may take a decision together with the family with full information. You see, disclosure is a very, very important ethical basis. Disclosure is the way you respect autonomy, right? Autonomy is not just a word or a concept. In practice, disclosure is empowerment of one's autonomy. So that you must do. Talk to the family. I think whether you are in a tribal area or wherever, you can use the vernacular. Be sensitive culturally to how you phrase your statements. And that is a part of our training, how you converse. So please improve this. We are not going to talk technical stuff with anybody, whether educated or uneducated. We are going to talk, with words which are understandable.
Thank you, sir.
There are no questions in the chat, but if there is one last question.
I would like to ask Ross, how would she tackle this issue? Brain hemorrhage in a tribal, huh?
A brain hemorrhage or uremia? I think I totally agree. I think it is about our best tools are our words, and we don't practice them enough or sharpen them. So the conversation, of course, somebody can have neurosurgery or they can have dialysis, certainly where I work, but it's what's the next steps after that? We are just prolonging dying. People, I think with this particular family, it would be about how can we ensure comfort for this terminal condition, rather than impose an economic solution, which is very short term and very costly. And I like the way you describe cost in terms of suffering rather than just money. And there's costs in bereavement as well. The more traumatic the ending, and we see a lot of traumatic endings, even in the UK, the worse is the grief. So I think it is about practicing, and it's about bravery, having brave conversations about prognosis. We don't always know what will happen, but we know what might happen as physicians and nurses, and we need to share what we think might happen. And often we know what will happen. So I think it is about being brave, and I think we have lost the courage for some of these conversations. But the more you practice and the more you have, the easier it gets.
Absolutely.
Sir, sometimes
I remember the first time I was called down when I was a young doctor to explain to a family that their father was dying from lung cancer. He had terrible pulmonary edema. We couldn't help him. He was dying in front of our eyes. And I remember how frightened I was at that first conversation. But like everything, practice doesn't make perfect, because we're never perfect, but it gives you a bit more confidence each time you have those conversations, and people are grateful for it.
Dr. Shweta, you had a question?
sir, sometimes the patient's relatives tell us that we should not intubate the patient. So is it the same as do not resuscitate? Or in that case, if we feel that the patient will require intubation or else the patient will not survive, should we use our discretion?
See, do not resuscitate is only referring to CPR. Do not intubate is a separate decision. Now, if there is a conflict with the family, whether to intubate or not, and the treating team believes that it should be, they should undergo intubation, the patient should undergo intubation, we have the first question to ask is, what is the disease? What is the prognosis? What is the expected benefit of the intubation? What is
Sir,
the
if
best
there is-
case? What is the best case scenario? What is the worst case scenario? Now, these have to be first discussed with the family. Now, if then there may be a chance that you may agree, you must aim for a consensus decision. Unilateral decision making is outdated, right? It doesn't sit well with the present day ethos anywhere in the world, right? We got to improve our outlook towards the patient. We are equal terms. We may be different in our knowledge of medicine, we may be different in our social scale, but we are the same. As far as doctor-patient relationship is concerned, it has to be equalized, otherwise we are not working according to the modern understanding of doctor-patient relationship, nor are we acting in accordance with the principles of ethics. So if there is nothing going for the patient on intubation, then you agree with the family. And you first discuss. It's not agreeing or not agreeing. Discuss pros and cons. Best case scenario, worst case scenario. Right? And then allow certain thinking with the family as to what they would like, and in fact what the patient would like if the patient herself or himself was capable.
Sir,
So
we face
I know this is time consuming, but it's not time consuming. As Ross said, if we practice at something, we get good at it, and it will take less time than you imagine.
Sir, we face situations when we understand that the prognosis is poor. The relatives are adamant that they will not intubate. So in that case, if we don't intubate, can we be held responsible?
Don't worry about the law. Worry
or...
about the patient. This is what I keep saying, because we lose perspective if we worry about the law. If we worry about the patient and it reflects in our work, then no law is going to hold you to account, because the law also wants that we work for the patient, right? Let's understand this. If our work doesn't reflect that we are patient-centric, then we are in trouble. So let us understand. If you think a patient will be helped with intubation, family doesn't think, they're adamant, as you say, you got to talk to them. There is no other weapon available to you, no trick. You got to talk to them. You got to wait for their understanding. And in any case, they have a right to refuse. That has to be respected. If after your persuasion, not coercion, persuasion, they are, as you say, adamant, then you record that there is a refuse, because without consent, in any case, you cannot introduce the airway. So that is the reason you have a documented refusal. So why would you have any problem with any law? And you've also attempted to persuade the patient. That is also to be seen. See, I'm sure if I were a judge, I will ask you, what actions did you take to persuade the family? So you see, I think we should shake the monkey off the back, monkey of the law, looking over the shoulder to the law. We are caregivers. We are not answerable to the law if we are doing our job right. And documentation is part of our job. Okay? If whatever you've done is reflected in the case notes, then you're all right. Then feel free to work for the patient. They are our true masters.
Thank you so much. I think there are a lot of takeaway messages, not just for me. I have I was reflecting on a lot of things, and we can see in the comments like people have different takeaway points from this session. And I think we have a big job to keep talking about this topic in various circles. Just have this conversation over and over till the practice changes. Thank you so much, both of you, for wonderful discussion. Thank you, Rose, and thank you, Dr. Raj.
Thank you.
Wonderful session.
Thank you, team. Thank you,
And all
Ross.
the questions from the
Thank you, audience.
participants.
Thank you, everybody.